And as you can see here, I mean, probably that CV is when I was much younger. Well, the good thing, the bad thing, I'm much older now. The good thing now that they moved since a couple of years here in Padova, which is a major, one of the most bigger cancer centers in the country. And the good thing that my paper now are something like 420, so which is good. Anyway, I'm so proud of being with you. It would be much better being in India at the moment. I would love that. But I mean, of course, because of the incredible problems we're facing through the last 2 years, we have to do this by Zoom, which is fine anyway. And what I have to talk about is precision diagnosis and impact on next generation sequencing and sarcoma. And you will see, I've been in the field of sarcomas and molecular genetics, I would say like approximately 30 years. So I'm a strong believer in medical in genetics in general, in molecular genetics in particular, but also try to raise some criticism regarding the way now we are currently, forcing sometimes genetics to the place it shouldn't be. So I will try to share with you, and then of course we can discuss a bit. So sarcomas, as you know, are very heterogeneous. They are rare. And because they are rare, sometimes diagnostic accuracy is an issue. You have to imagine that approximately 1/3 of cases get misdiagnosed anywhere in the world you are. Italy, US, UK, India, anyway. This is not because pathology is not good enough, but because, of course, rarity affects by itself diagnostic accuracy. On the other hand, pathological diagnosis is the rational clinical decision making, but not only, you don't only want to have a label on your case, but on your patient, you want to hear from her some prognostic indication. More and more, you would like to have prediction of response. And, conventional morphology is still a powerful tool, even if I've been working extensively in immunohistochemistry and molecular genetics of sarcomas. I would say, don't forget that there is one very antique instrument, which is called microscope, which is still very powerful. So if you ask me now, should molecular diagnostic raise morphology? Well, the answer is pretty easy. It's no. And why is no? This is kind of an old paper published in OncoTarget, where basically they decided to cancel pathology and to move to a classification based on morphology, which is, by the way, is exactly the way we classify cancer nowadays, with probably the exception of brain neoplasm. Well, into a molecular-driven type of approach. All right, if you take ALK or ALK rearrangements, if you want to be the expert or the oncology expert of ALK rearrangement, then you have to be able to treat lymphomas, to treat lung cancer, to treat neuroblastoma, to treat sarcoma like IMT, and so on, so on, so on, so, or renal cell carcinoma, which is not exactly the trajectory that we want to design when we talk about precision medicine and precision oncology. If you want to be precise, you need to be competent, and you can be competent on everything. But more seriously, one of the issues we have, which you always have to remember, that, when we started looking into the genetics of sarcoma many, many years ago, at the very beginning, we were enthusiastic because, okay, we found one gene fusion, and that should identify a specific entity. And now we know that was very naive to think. But we were at the very beginning. So, for example, if you get the ZWS ATF1, you can have either in clear cell sarcoma, so-called melanoma soft tissue, very aggressive lesions, or in angiomotor fibrous sarcoma, which is a quasi-benign thing, very exotic. So basically, now we know that genetics is important, but need to be spent in the context of morphology. Since many years ago, with the French friends, we tried to see how was the impact of molecular analysis on the final sarcoma diagnosis. It is very big, of course. Even more now that we have at hands what people tend to call next generation sequencing. And actually, we call it massive parallel sequencing, and which is the best way to call it. And what we actually do one thing when you want to run, big experiments on the hypothesis generating type of NGS or MPS, as you prefer, all these kind of omics or transcriptomics approaches or metylomic approaches. But most of the time when you go to diagnosis, we use more target MPS or target NGS, in the sense that we're going to interrogate a limited number of genes in order to get diagnostic information. And this has become very much important to validate classification, to identify more diagnostic marker. Think of STAT6 in solid fibrous tumor or cyclin B3 in Bicorp sarcomas. All these data were originally generated by next generation sequencing studies. Or the new tumor entities like the SICDUX and the Bicorp sarcoma that will be briefly mentioned, and so on. Or think of, the big obsession of this last couple of years, so the NTRK rearrangement with the potential for target them with anti-NTRK drugs. So let's just mention briefly how relevant has been molecular genetics in order to identify new entities. And actually, these new entities has been now in the new WHO classification that we just published 1 year ago. I've been in the WHO committee for the last 20 years, so I could be part of the progressive changes that's been introduced in the way we currently classify these type of cancers. And okay, what is SICDUX sarcoma? Well, it's something that since a few years ago we classify within the umbrella of Ewing sarcoma, with two problems. That they didn't look so much like Ewing sarcoma. That's why we called a few years ago a typical Ewing's. And the second point, from the treatment standpoint, these patients almost never respond to the Ewing sarcoma protocols as should be expected. And the reason they didn't is because they were not Ewings. And basically, you see, they are mostly soft tissue lesion with a peak incidence in the third decades, and you see it occur basically anywhere. And sometimes they are round cell, they show round cell morphology, but many other times they have very, very different morphologies. And the important thing, that consistently they show rearrangement of the CIG gene, sometimes with FOXO4, most of the time, but could be Lutec and so on, or most recently, some rearrangement with the NAT family of genes has been also reported. The second entity that was found thanks to NGS from MPS is the so-called Bicorp fusion positive sarcoma. They are more common in bone, with a peak incidence in a younger age, you see the second decade. Again, kind of very variable morphology. But the base question that the clinician would pose to a pathologist is how you reported two new things. So what? What is that the clinical behavior is very different. So Bicorp tend to be less aggressive. Definitely CHIC is very aggressive, probably more aggressive than Ewing's. And of course, at the moment, we don't have selective treatments for this group of patients. But more and more we start thinking, okay, maybe we need to think of something specific for these, subgroups around cell sarcoma that don't get much benefit from conventional Ewing protocols. But, there is any medal, any coin has two sides. So we were happy when we have new entity which looks consistent both from the genetic and the morphologic and the clinical standpoint. But sometimes, and this is the bad side, the dark side of NGS, if you keep on, looking for new fusion, then you end up with kind of PRX, NCOA1 distinctive fibroblastic neoplasm, 2 cases. EWSR1 SMA3 positive fibroblastic tumor, 3 cases. No clinical correlation, no information follow-up. So the reaction of you as clinical colleagues may be this one, like the famous Munk in the screen. You got lost. You don't understand what is the value. And in fact, with some of friends like Paolo Casali and Alex Garonchi, we try also to reason a little bit, what is a new sarcoma? Because I don't think it's just a new cluster. morphological or molecular. It's something more. It's an integration of morphology, clinical history, outcome, even treatment if you want, but it's not just a molecular variant of something. We don't know what it is actually. And, this is very much important because more and more we are linking histotypes to specific therapies. I know we don't have time today, but of course, gastrointestinal stromal tumor GIST are by far the best example on how you can handle specific treatment. And if you think now we have on GIST imatinib, then sunitinib, then regorafenib, then abritinib, and then repritinib, so many things. Or if you think even on mixed cell liposarcoma, which is a very chemosensitive entity, we know that, for example, you can use drugs like trabectedin, which is less toxic and equally effective on this type of lesion. Or think of denosumab in giant cell tumor and original bone cysts and so on. So, but the main question, going back to the topic of my talk, is do we need molecular genetics as predictive biomarker all the time? Well, the answer is yes and no. Sometimes you need, like in GIST. Sometimes you need, like in IMT, because you want to get a rearrangement of ALK, of ROS1, sometimes RET, sometimes NTRK. But in other situations, molecular genetics is not useful at all. So again, these are information that need to be discussed within a multi-professional team of competent specialists. And we have the biologists, the molecular geneticists, the pathologist, the surgeon, the medical oncologist, the radiotherapist, and so on. So we need to be a team in order to handle all these kind of new informations. But of course, MPS and genetics is so important to identify new potential targets. Just think of epithelioid sarcoma. Epithelioid sarcoma isn't a horrible disease. I don't want to bore you, but the classic type that occurs in young patients on the distal extremities. When it recurs, tend to recur more proximally, and basically has been for years and years an orphan disease. This is one of the type of surgery you get. It is a typical morphology, which tend to be sometimes very challenging for us as a pathologist. Then, of course, the variant, which is called proximal type, simply because it occurs not distally, but proximally in the body. They are more aggressive. This is the morphology, and it looks very much like a very aggressive neoplasm called rhabdoid tumor. What is important here? Well, these unfortunate patients get through multiple recurrences, high metastatic rate, very, very aggressive disease. And we tried also to see whether we can have prognostic parameter. Actually, we found one morphologically. We can predict epithelioid sarcoma of the classic type will behave more aggressively. But the important thing that we know that genetically, we have loss of one specific gene, which is called INI1. And why this is important? Because if you lose INI1, then you upregulate a molecule called EZH2. And because of that, it was possible to develop a specific drugs to upregulate EZH2. Well, this is only 20% of the patient. You can see some of the patients don't respond if you look at the waterfall plot analysis. But 20% for such a horrible disease is far better than nothing. So the key point, we have a broader spectrum of drugs, and of course, we need to recognize them properly. And what about, new targets? It's quite interesting, but many years ago, I'm still interested in so-called wild-type gastrointestinal stromal tumor. And just by serendipity, we found NTRK gene fusion in GIST. And this is interesting because now, retrospectively, this was the start of a big story. And then you know that now there is a huge interest in TRK receptors that, of course, they mediate neurotrophin signaling. But the important thing is that, you may have numerous TRK gene fusion across different type of tumors, including many sarcomas and pediatric sarcomas. You know that these drugs has been, in a way, approved agnostic specifically, so you can target the molecular aberration, not specifically the disease, which is important because otherwise it would be difficult to have a approval of a drug like that, which is very expensive in so rare things like pediatric sarcomas, which is a good thing. But these rearranged and tract rearranged sarcomas are very rare. So just forgetting infantile fibrosarcoma, which is a well-established entity, now we have this type of lesion that sometimes is difficult to predict the outcome, so-called hypofibromatosis like neural tumor, which is a typically pediatric infiltrative lesion. And you may say, okay, but they don't never get metastatic. All right, but sometimes they get so big, then, surgery will be mutilating. So downsizing with the anti-NTRK drugs could be a good strategy. And then we have the so-called tumors resembling peripheral nerve sheath tumor. Here, PNST is an emerging entity. This is NTRK positivity. And of course, this type of neoplasm can behave aggressively. We don't still have a huge experience because they are so rare, but they can behave aggressively. And so within the so-called World Sarcoma Network, we decided to develop a strategy because, you can't sequence by NGS all sarcomas. It would be unfeasible, impossible, too expensive, and we basically would use my lab, which is pretty big, only to deal with NTRK. But you can use immunohistochemistry as a screening tool, and then if it is positive, you can decide to go NGS to prove the presence of the fusion gene. So again, as you can see, NGS in a situation like that is very, very much important. Of course, the perfect NTRK fusion test does not exist. So we need to do what we can do. What I do in my lab which is a centralized lab for many, many molecular predictive biomarkers for a huge area. Well, what we do is use immunohistochemistry as a screening test. If it is positive, we go and try to prove the fusion because it is the fusion that predicts the efficacy of the treatment. And going to the end of my talk is that precision oncology. What is precision oncology? Well, it's when we try to tailor the treatment on the basis of the genetics. Sarcoma is kind of a challenging thing. Well, of course, I'm very much in favor, chairing the molecular tumor board of my hospital to try to find any solution for a patient failing on a conventional therapy or target therapy, not a problem. But when you think of precision oncology, you should always consider one important paper published a few years ago on the New England Medicine, where they show that, some metastases from the same tumor, they do have the genetics of 4 different tumors. So when we follow the dream of, okay, if I know all the genomics of one metastasis, I will cure you. Don't forget that the other metastases will only share with the one you analyze no more than 30% of the genetic aberrations. So this is a major limitation to what is currently called precision oncology. But this doesn't matter that we shouldn't try. The other bad news is all the time we try to answer the question, but if we know everything about the genomics of our sarcoma patient, is the outcome going to be better? Well, unfortunately, the data that we have at the moment are negative. So we can prove could be many reasons. Some of the study are retrospective, so maybe we need prospective study, which are, ongoing. But at the very moment, we start from a situation in which the information we have are not so good. This is one of the paper. This is another of the recent paper that's been already published. And you see, our data suggests that molecular profiling should not be used in routine practice. This is where we are. Clinical practice is one thing, translational research is another thing. So I think we should keep on, working on this field. Because we know that, to identify a target, then you need to develop cell-based disease model on maybe animal models, then you go into the pharma, then you do your translational research. This is a long process. So we can't use, shortcuts because otherwise, we don't produce good translations in medicine. And also the other point is that we need more people, more skills. You know, it is not just pathology when we go into the genetics. It is pathology, but it's also clinical interpretation, is also bioinformatic elaboration, is also, you know, sharing of different expertise in order to get the best use of this important genetic data. So my conclusion, okay, sarcomas are still a challenge, is a global challenge. What we need is precise diagnosis. And of course, we have situations in which genetics can be very helpful. But don't forget the morphology is still the mainstay of therapeutic planning. And we need to use molecular testing, but should be wisely used on morphology. And I wish to thank you for inviting me. Also remember that my university this year has an important birthday, 100 years. And of course, we hope to be, you know, we are proud of it, of course, but we need also to work hard to keep the name of our university still high. Thank you so much for inviting me.